Good afternoon, everybody, and welcome to today's deep dive session. I apologize for being 2 minutes late, but it seems like my Wi-Fi is not working at all at the moment at home. So I'm on my phone at the moment. So unfortunately, I won't be able to show the slides from here. If anybody else has control over the slides, please do. But it gives me great pleasure today to introduce three speakers to start off with. Professor Estelle Verburg, who needs very little introduction to this group. She's a senior consultant and associate professor in clinical hematology at the University of Cape Town and Groote Schuur Hospital. For those who are new to the group, Estelle spent many years working in Belgium in clinical hematology, where she also completed a PhD working on the prognostication of myelodysplastic syndromes. Did some very important work that was eventually incorporated into the WHO classification. And yes, that's for another day. As you will see, there's going to be some other interesting things that Estelle will talk about today. Then we've got Dr. Simba Kudakwashe. Now, Simba is originally from Zimbabwe, and he did his fellow training in clinical hematology, as well as his internal medicine training with us at Groote Schuur Hospital. And passed his exams, became a clinical hematologist, and is now the very first clinical hematologist in Namibia. Very proud of Simba. He's done some very interesting and important work in lymphoma and transfusion, and also published that recently. So Simba, great to have you here today. And then last but not least, Dr. Catherine Antle. Catherine also did a fellowship in clinical hematology at the University of Cape Town, Groote Schuur, in our unit. Catherine subsequently went on to do a PhD, working on a variety of aspects related to lymphoma biology, but in particular, and very relevant to today's discussion that Estelle will also talk about, she worked on the development of a rapid access lymph node biopsy clinic, which is currently sustained by the team under the leadership of Estelle, and Simba also played a very, very important role in that in his time. Catherine, after completing her PhD, went off to Harvard, where she did some very interesting molecular work, and she's back at UCT continuing this work. So it's great, Catherine, to have you here as well. So with that, I am handing over well, almost handing over to Estelle. Just a few housekeeping rules. If you've registered for the session, then you should automatically get your CPD points if you are from South Africa, because the system will send your details through to the HPCSA if you attend at least 1 hour of the meeting. Also, if you are not from South Africa and you need a separate CPD form or a proof of your attendance, you can email our team at the, I can't see at the moment because my screen is too small. Oh, there it is. You can see the email address is on the screen, melanie.davids@uct.ac.za. The meetings are all recorded, and the recordings are made available also of past sessions at bloodsa.org.za. Really want to encourage all of you to have a look there. There is a wonderful, wonderful collection now of past presentations that is an absolute treasure house. And for those of you who are studying towards your hempath or clinical hematology and even internal medicine degrees, there's a wealth of information that I think you will find really useful, especially as this meeting is primarily aimed at our trainees. But you'll also see that the specialist clinicians, both in private and in public, will tell you exactly what our modus operandi is in practice in managing these patients. With this, I will hand over to Estelle, who will talk about the RADLAC, or Rapid Access Lymphadenopathy Clinic, and the practicalities around it will be discussed by Simba, and then the power of lymphoma registries and repositories. We'll get some feedback from Catherine. At some point in the meeting, I will unfortunately have to leave for a hospital management meeting, but I'm sure Estelle will keep you entertained to the very end. Thanks, Estelle. Over to you.
Thank you so much, Vernon, for the warm welcome for all of us. It's great to be with you. So let me just see. It's actually nice to just chat and to start. It's great to see there's some trainees, because it really is. We had, when we did the survey of the last year, there was some feedback which was not something that we didn't, it was not surprising at all. People liked us to be sometimes be not so high, not so, but be very, very practical, and patient cases, and really getting to the patient. So I'm only going to have one patient case today, but I hope it really is a case that speaks to us, and I cannot think that there's a doctor in South Africa who hasn't seen such a patient before. So without any more ado, let me start. And yeah, let me get, ooh, my, there you are. Okay, so I think everybody can now see my screen, but not yet my, there you are. Is that in order?
Perfect.
Great. So lymphadenopathy is one of those general clinical signs. Sadly, should have been a whole system on its own, because actually it's part of a system on its own. The blood system, which is pervasive in the whole human body. And if there's an area that it doesn't come, then we all know that it's not really part of the human body. Well, I think certain appendices, like our nails and our hair, has had a very good supply of blood and doesn't need so much of that. But truly, the lymph canals, the lymph nodes, the bone marrow factory, the blood vessels and the blood within it, the thymus, if you want, the spleen, if you want, all of that is a big system. And I think that lymphadenopathy in a HIV/TB endemic region like ours is very poorly understood often, because of the fact that it becomes almost like the background. It's basically not even seen. So my case. So now everybody must agree with me or disagree with me if this is a case they may have seen before. So this is a young man, 30, presented June 2021 with abdominal discomfort and constitutional symptoms at a secondary hospital in our region. So I don't know what you think. There is no tracheal deviation or airway cutoff. Is there something else we see? There's a widened mediastinum with silhouette sign. There's no cavities, nodules, or consolidation. And then there's something I see here, because I know, I'm in the know, but perhaps there's something else that's not immediately so evident, that could have been a clue to the person examining this patient. And I wonder if there's anybody who wants to venture. There's something in the soft tissue here that may give a clue, apart from what's seen on this chest X-ray, which is obviously a deeper layer, but there is actually something else. See, so we all agree, I hope, that this is a diagnosis of lymphoma until proven otherwise. Agreed? Until proven otherwise, in a 30-year-old man, this is lymphoma.
I see Jacques said in the chat, axillary lymph nodes, Estelle.
Yeah, yes. So, I mean, I wouldn't have seen it, people, but if I'd examined the patient, I would have hopefully felt it. And this patient told you very beautifully, I had big lumps under my arm. And I think today I'm really going to take some time, thanks Catherine, to drive home the message, because I've spoken about this often to different audiences. And I find that what I think is very clear and logical may not be so for a TB expert in Durban or a GP in, Pretoria. It may not be so evident. I may think it's kind of logical, but we are confronted with these things all the time, and now we are very clever about it. But perhaps we must try to put ourselves in the moccasins of our colleagues who have 500 other diseases to think of. So yes, there's definitely that. And if the patient had been examined, but also because what happened then, if somebody had looked at this X-ray, because it seems nobody did, then they would not have taken out a lily white appendix. So that's actually what happened to this young man. He got an appendicectomy because he was having constitutional symptoms, and it was misunderstood as being abdominal pain, let's put it like that, but it wasn't really. But that was what, for the clinician who saw him, explained something. But clearly there was not a good systematic questioning as well as examination. So again, I always try to be very fair, or very, slow to pretend that it's so easy, because again, it's our art and it's our disease area, and it's the patients we see. So obviously it's very important for us. And for a generalist, he may feel bumps often and not know what to do with it. And then certain rules get lost. So I think what's important here, and that's now part of the training of today, the important thing here is if there's a mediastinal mass in a young person below the age of 40, then truly the other differential diagnoses become if there is something strange else, like a thymus or something, a bronchial cyst or whatever, or TB for that matter, then I do think you must still rule out lymphoma first. So that's very important. But even if a patient is 50 and 60 and a smoker, I still think that this is quite lymphoma-like, and I think even a generalist will agree with me. But I think the problem is that this is not fitting into a generalist's mindset. So it kind of stuns them and they just go past it. If there was a big, round nodule, something there, or there was specific cavitation, it would have fit, and it would have been much easier for a generalist to put in place. So, so it's just important to remember that there are still quite easy rules about lymphadenopathy. Lymphadenopathy that's painless, that's rubber hard, that's more general, not connected to a specific wound or something. Those kind of lymphadenopathies, if they stay more than 2 weeks, 3 weeks, then they actually deserve to be examined very thoroughly, which usually means not an FNA, but histology. So we'll get there. So let's just go to what happened to him. And now I'm going to have a very sad slide. I should have used weepy symbols, but this is a very sad slide. And today, just to tell you where we're going, we are going to look at the results of our lymphadenopathy clinic. And we're also going to chat a bit about where we're branching out from here. And remember, we're now going to start thinking health economics wise, and not only accuracy, because diagnostic accuracy is what we kept ourselves busy with, and that Catherine did a lot of work on. But after you've gotten to this diagnostic accuracy, what about thinking of the cost? And there's a cost to tests, and there's also a cost to life. So if a Hodgkin patient dies at diagnosis, that is a very, very, very high cost. and a very unnecessary cost. But there's also cost to tests. So let's see. This patient had an appendectomy, so that's a huge cost. Then the patient had, and why did that happen, the appendectomy? Because somebody wanted to do something and was pressurized for a diagnosis and didn't go through the system of the patient. So then 3 months later, this poor man was still not better, feeling worse, had a negative gene expert on sputum. I always wonder why people start with a gene expert on sputum in an HIV negative person that has a big mediastinal mass. But anyway, at that stage, I think another photo wasn't taken. Would have been nice to have looked, don't you agree? Look back to the June photo and they would have seen this photo. So then 3 months later, he was really at the end of his tether and feeling very poorly. This X-ray is obviously not the X-ray after 6 months. We will see that just now. So he wasn't looking like this. It was much worse. So now they again do a gene expert, and the culture had also come out later, obviously. That's the problem with the TB culture, a gold standard, a good test, but it takes 6 weeks. And then, the pleural fluid is always the next thing. And there's always a looking for TB and not for other things. Again, a young man with a big mass and lymphadenopathy. So he is actually saying, come do some point of care testing on me that could actually help me from dying. Then on the same day, obviously the inevitable FNA of the axillary lymph node. And obviously, what do we see with lymphoma? If we see anything, we see reactive lymphocytes. Because we all know the cell of origin theory of any kind of cancer. So if the cell of origin in a lymph node is a lymphocyte, and it's the cell of origin for the tumor, then why would it show itself to be malignant unless you see the architecture, the matrix in which these cells are being abnormal? So then a month later, so he must have had a very unpleasant new year. And then there was a negative TB blood culture, still somebody who's HIV negative, had a myriad of negative TB tests, and an FNA of the cervical lymph node is again done, which is almost required in our region, 2 FNAs, usually a month apart. This was actually very quickly, and the same non-specific reaction. So then, what's that? 2 months, a month later, he is truly now gasping. And again, cytology on the pleural fluid is done. And this is all happening in a secondary hospital, and some of it in clinics. And the cell block failed. So I just think of the cost of what had been happening. So then, in February, at that moment, when this person is clearly near to death, a nodular sclerosing Hodgkin lymphoma, the diagnosis is made. And he's probably had it for about 2 years. So these are the patients which inspire us. And we are always looking at them to see, can we find a pattern? Can we find some nugget of wisdom that we can share, that we can help other doctors to diagnose them better? Because we're always at the receiving end and not there at the coalface where these patients present. And I think it's this that was the inspiration for our clinic. We realize that lymphadenopathy is assumed to be TB. We have to accept that. But what doctors don't know, that the paucibacillary nature of a lymph node means that putting a needle in it is actually a very useless and a very, very low sensitivity test. So you're not going to get your Zeal-Nielsen positive from a simple FNA. You also don't get any cytology that's of any worth. And a granuloma per se is not a diagnosis of TB. So the other causes of lymphadenopathy and how to diagnose them is just as poorly understood. So in South Africa, the road to lymphoma diagnosis is littered with negative sputum expert and negative lymph node FNA. And I do hear from my colleagues in private practice that although often patients are speedily and expertly diagnosed, if they get to the wrong caregiver, there's also a lot of delay and misinterpretation of actually signs that should be quite clearly a lymphoma. So this leads to the empiric and erroneous TB therapy at diagnosis of many patients. And that has been noted, reported at many hospitals. I'm just naming a few. Tygerberg, 25% of a population with DLBCL, 88% at Impangeni of a population of lymphoma patients. And then Prof. Opie's paper on Hodgkin, a very high percentage of patients being examined and or treated for TB. So I'm now gonna, so before I show the video, it's a video where Catherine speaks about this clinic and where she tries to lay out very clearly why we thought that it's a good idea to build such a clinic. And we had lots of help, lots of people who did this. So let's listen. I don't hear the sound. I don't know if others can hear the sound.
Estelle, we can't hear the sound on this side as well.
No, also
Enlarged lymph nodes are a common clinical problem in Southern Africa, the more so because we are at the epicenter of the HIV and TB epidemic. Lymphoma is a cancer of the lymph node. It is the 5th most common cancer globally, and in developed countries, the most common cancer in people living with HIV. Lymphoma is a very important cancer of the younger patient, irrespective of HIV status. The dilemma in Southern Africa is that lymphoma and TB share overlapping symptoms, including enlarged lymph nodes, fever, and weight loss. They also both occur more frequently in people living with HIV. When these symptoms are investigated suboptimally, it may lead to the diagnosis of lymphoma being made very late. Whereas lymphoma is highly curable when diagnosed and treated early, a delayed diagnosis can cost a patient's life. Within a TB endemic area, and due to clinician bias towards diagnosing TB, tragically, lymphoma is frequently misdiagnosed as TB. At Grooterskuur Hospital in the Western Cape, we have created a diagnostic pathway to address this issue. We employ accurate point-of-care tools to differentiate between lymphoma, TB, metastatic cancer, and other causes of enlarged lymph nodes. We found the 2 top causes of enlarged lymph nodes in our region to be lymphoma and TB. Our vision is to educate healthcare workers and empower them with best care practice for the early and accurate diagnosis of conditions causing enlarged lymph nodes. To achieve this, we have created a rapid access clinic where we have developed a best care diagnostic pathway. This pathway brings the required tools right to where the patient is and equips the healthcare worker to use these tools effectively. These tools include the newest generation TB test and a core biopsy. This vision will be rolled out to other centers in Southern Africa as a modern and direct solution to the dilemma of accurately diagnosing the underlying condition causing enlarged lymph nodes. This will enable the early and accurate treatment of lymphoma to improve patient outcomes in Southern Africa.
great. I'm going to start sharing my slides again. So I said there will be tears, and there was the happy and lovely crying of a beautiful young baby. So that was luckily not a tragedy, but so apologize for the sound. But I think what I wanted to show is what we did just before lockdown. We started moving out and doing these type of workshops. But then lockdown came and it really put a stop to the work that we intended to do. And now we are going to start rolling out again as part of different initiatives. But let me just continue. So one of the greatest slogans, in a sense, that I got at that first outreach or workshop, training workshop that we show, is one of the doctors of Makwasi Hospital Clinic, part of Tygerberg Network. And she said, "I do not know what is wrong with my patient, therefore I cannot refer to any specialistic service, yet I do not have the diagnostic tools to attempt a diagnosis myself." And that's truly such a heartbreaking announcement. And that is what our doctors find themselves in. And somehow they must get through their workload and the 10 minutes they have per patient. And they have no recourse to good diagnostics. So let's show what we have done and what we have been able to teach to certain of our regional network in the Cape Province. So we've reached out to Tygerberg, where there's already a fantastic FNA clinic, and where they can probably diagnose lymphoma on FNA, but where Dr. Levakan actually started doing these tests together with the surgeons. So a little bit more about the surgeons later. So how do we start, and what is the one test where we are giving TB its due? It's the FNA Ultra Expert, which was just 1 log more sensitive than the expert that was used at that stage. And we combined it with a gun biopsy to get to histology. So those are the two messages that we have, and both are at point of care. So using this little system that is actually point of care, but that, as we all know, is not necessarily used at point of care for the testing itself. It usually gets sent to a big lab, but theoretically that could also be done in the clinic, right in the clinic. It could be tested, and there may be places, perhaps people are in this meeting, that have a true point of care expert amplifier. But that is the important test, because we have to face the fact that there will be 10 times more TB than lymphoma, but really there's not 100 times more TB than lymphoma in lymph nodes. So we must get to the very important 10% of people. So sometimes TB is the issue, and we are willing to concede that, but we have to do a rapid access core biopsy too, unless we think it's TB, and we'll get to that later, to get a proper histology diagnosis. And there's many reasons to do this, not only for lymphoma, but sometimes it's even absolutely necessary to get to a diagnosis of a metastatic lymph node or a TB lymph node. So for that, we do the very accurate point of care testing with a barred biopsy needle and a 14 gauge needle. Now, I'm going to show you something just now where our surgeon is going to chat, because as we know, tissue is the issue in soft tissue masses. So this is the algorithm that Catherine started out when she established this clinic. And so if there was caseous material, then patients only got tests for TB to start with, the ultra plus the normal TB tests. When there was no caseous material at the beginning of the clinic, patients got obviously the smear microscopy for AFBs, still very useful, if there's a false positive ultra, for example. And also, it's just a test that while you are checking the validation of the ultra, we are still doing. And then the cytology was done in the first 52 patients. And why do you think we stopped at some stage? We found that it's only in the older person who has a metastatic cancer in the lymph node that cytology of a lymph node is of any use. So the figure here is the first 52, but actually it's only when people are above 50 and you truly think that this is a cancer. There's a prior history of cancer, or there's a specific lesion that's seen that looks cancerous and not lymphomatous, that cytology is useful. And then the tissue specimen, and so I will just show how we have actually adjusted it, that if it's caseous, we only do the aspirate, and the AFB is still there, but it's just a little bit less important. Why? Because it's not sensitive, because it will only be positive, it will only be there in 10% or 20% of people who actually have TB. And then the tissue specimen, if one does that, one does not have to do an aspirate. So you can leave out this, and I'm going to get to the costs just now. So you can actually leave out a whole extra costing and just do the ultra and the culture and the Zeal-Nielsen, if necessary, on the histological specimen. So this is the paper that showed the accuracy of this expert test in tuberculous adenitis, and obviously it also ruled out and solidified and supported the fact that when we did histology, we got at least a quarter of patients with lymphoma. So the sensitivity is really good, but it's not perfect. And if we look at the acid-fast bacilli here, we can just see, how incredibly low this is, and how low chance one has of actually getting a proper TB diagnosis by just doing a simple FNA. Nevertheless, in this country daily, people continue doing tests on lymph node without doing a specific focused TB tests. And, we argue that patients, there's such a high attrition rate. It's so difficult for patients sometimes to come back to clinics. In Baragwanath Hospital, there's been a great study done by, the pathology people as well as the clinicians, where they could show that people who actually had a lymphoma on their cytology, only half of them came back, and that of all the people being tested with FNA, a huge amount, can't remember now the exact number, but about 70% of those people had passed away or were not couldn't be found after a year. And that's what one also thinks sometimes. Why? And that is like a snapshot. It's a cross section of data. But don't we sometimes wonder what happens to our patients? And don't we sometimes realize that our pathways are not always very good? We have found, now that we work in a registry and in a database, we have found that some of our lymphoma patients actually were lost to follow-up after a few courses of chemo. And that happens with us. It's the type of thing that happens. And it's that's a read in a database actually stops that kind of thing from happening, because now you can have a very, very good way of seeing people haven't come for their chemo. So I am, speaking of attrition, it's not only out there, it's ourselves that have to watch that our patients are coming back and get cured. So this is just to show, and that's just the point of this slide is obviously the fact that lymphoma makes up at least a quarter, TB a bit over a third, and then the malignancies are about 17%, also in the updated paper at 17%. So these are bad news because they are metastatic cancers in a lymph node. So that is truly bad news. This is not bad news. Lymphoma can be cured. We'll get to that later too. So just explaining what I said about only doing FNA when there is caseous material, we can see that in this group, it made sense to only do the ultra. And in those who were negative, the patient could be followed, and it did turn out to be a more a bacterial adenitis or an infection of the lymph node. But and then the other important group that's very small, but where we absolutely want to be in good unity with our ENT colleagues, is to make sure that we don't do biopsies and look at cases that actually should be in their domain. And they teach us if it's a cystic mass, if there's clear fluid, if there's hoarseness, if there's difficulty swallowing, those are the patients that we must discuss with them. And these get cytology and these get ultrasounds and get referred to ENT. But the other lymphadenopathies, which are rubber heart, typical lymphadenopathy, on them, we prefer to just do a core biopsy, a point of care core biopsy with this accurate gun. And we believe that we can get good enough diagnosis with this. So let's see why I'm now not able to move. There you are. So this is just the recent publication, and I want to just quickly show a few things here. It's exactly the same scheme where there's a portion of patients that has the TB of the lymph node. And you can see here that the AFB, let me see the AFB positivity. Can you see how low the AFB positivity is here? Terribly low. It's actually, isn't it 9? So there's 9 of 94 that actually had AFBs. I hope it's correct, Catherine. You can correct me if I'm wrong. So you cannot do a cytology on the TB patient and expect to make a diagnosis. So it was definitely the culture, and it was the gene expert, and sometimes a composite of certain findings that gave us the diagnosis of TB. And then with the lymphoma, and as well as with the other malignancies, a diagnosis could be made on a core biopsy in more than 90% of patients, 95% of patients. So it was definitely good enough to make a diagnosis, because the gauge of the needle we use is good. And I think I just want to stand, just stop a little bit there. It has to be a big gauge needle. It can't be a 20 or an 18. It has to be a 14, preferably, or if you truly can't do a 14, a 16. And Simba, I'm happy if you tell me if you don't agree. So then there's a few other strange and interesting findings, obviously, on lymph nodes, which we will not continue on. So
I agree still.
Yeah, thanks.
I do agree 100%. Thanks. All right.
So so there's the I think I've said this already, but as I've learned, I think it's very important. The lymph node in our clinic is typically more than 2 centimeters. And now we're going to get to chat to Simba. Now, what the point here is that I find that our untrained, and if I say untrained, I mean not untrained, our non-surgical, non-radiology fellows are absolutely adept at doing this. And they take centimeters of lymph nodes of 1.5 centimeter and manage to get diagnoses out of them, which the ENT's colleagues tell me is not possible. So they truly are capable of doing it. And so let's move on. So Simba, what I'm going to show now is just the the training videos that Francois made. I don't know if you want to start with, chatting before we show the video, just chatting about this, your experience in the clinic. And then what I wanted to show is just when Francois chats about the needles. I thought that was kind of cool and gives a bit of training and insight. So what do you say, Simba? Tell us about your experience.
Yeah, okay. I think, okay, let me just, probably I can just start a bit with the experiences that I got. Okay, can everybody see me?
Yes.
All right, okay, that's lovely, okay. Yeah, I think, first of all, I'd like to say, thank you for inviting me into these deep dive sessions. These are always fulfilling, and I'm always excited to talk to colleagues, about our experiences. So what I'm just going to do today is I'm just going to talk about my experience with this, rapid access lymph node diagnosis. So for me, what is quite interesting is that, I got involved in a way, it was sort of like, things just happened, because when I, started my training, this is when probably this program was heading on, and Catherine had started a good job. And I think at that time she was about to go to the States. So I then took on the baton, and it was really exciting. So basically, what I'm going to talk about here is I'm going to talk about, the time that, I was involved, and also just to talk about if there are any complications that we can expect, and, what kind of size of nodes. But again, like what Estelle said, that the nodes actually depend on your experience, because as I got to know and to do this more often, I was busy squeezing off the nodes, even 0.75, you would squeeze it, and then you would, you would get something out of it. So I think, 1.5, yes, but I think 1 centimeter, if you've been doing it for quite some time, you can actually do it. And also the issue of using an ultrasound scan. So initially, I was also using the ultrasound scan, but with experience, that mustn't be a hindrance. I think the ultrasound scan, one can use it when you are near big vessels. When you want to use the Doppler to check whether, is it a big vein, is it a big artery, or is it pulsatile? Then one can do that. With regards to the whole picture, I think what is important is to make sure that you've got a good, streamlined, system. Like, for example, at Kutiskye, we had this booking system that was being run by Jenna, and also Karin was also involved. So I think I would also need to acknowledge them, because they really helped a lot. So what they did was the patient would book on a red cap system, and then would get the phone number of the patient. And then what we did was we looked for a day where we didn't have a lot of work, because what you need to do is to create time, and then you can tell them to come at a specific time. Because I think patients really appreciated that, because what they realized was that they would come at around 12:01. Some of them will come at 2 African time, you know how it is. But what would happen was, once they got there, they will get the service very quickly. And actually what we did was we actually let the receptionist know that these are patients for lymph nodes, and this is what they, we need to treat them. So it was easy for them, and would just start and see them quickly, and then they would go home. So I think just to have a system that is, that works for whatever unit that you have, because what will happen is once people start realizing that there is a good service, the numbers will start rolling in. So it is important for you just to have a system, just to book them. And the other important thing that I noted was good communication, because it is important for people to understand that if it is an emergency, like for example, a big node that is probably compressing the airways, then one has to get, access very quickly. And also you as a clinician, when you see that this requires emergency, then, you need to step on it, call the pathologist, and also you can even have imaging even before, and also do other tests that, when you're trying to look whether this is a lymphoma or not. So I think that's the most important thing, that when you're doing this, make sure that it's also part of clinical, that you don't, separate these things. If you think that this patient has got something else that needs to be addressed to, you also address it. And for the complications, there wasn't anything much. It was just a bit of bleeding, so that you would get away with compression. And then what I did is, I then used my GP tactics. You can apply cyclocapron topical whether it's you just break a pill and then you just put it there, or you can, or you can use a vial of cyclocapron and also topical adrenaline, and then you just compress. So usually the bleeding would stop right away. And what was interesting was usually the perceived pain, because when they would come, they would see this thing and I'll be worried. But after that, they will be very comfortable. And then for patient experiences, they really, really liked it. And what they appreciated was the time, because it was well streamlined and they got there in time. Within an hour, they get the service and then they will go home. And then the other thing also was that the apparent, pain and all that, they realized that, no, this is not very painful, even if you call them to come back. Because again, I think we can't stress the importance of getting the phone numbers. Make sure that you get 2 or 3 phone numbers that work, because what will happen is that you will get a diagnosis of a high grade B, and then the patient was lost their phone or you can't get hold of them. So I think it's important to get the numbers that are working and then you contact them. So I think that was important. And also when the diagnosis is non-diagnostic, to repeat the biopsies. So having said that, I would like to move to the, to the Namibia experience. And yeah, so just a disclaimer, I think Prof said I'm the only one, we are 2. I think I've got also Dr. Honest Dewa, who is with me here. We almost started at the same time. So we are doing private and also helping in the government a bit, just to try and see how we can help. And in the private sector, honestly, the biopsies are mainly surgeons-based and the access is quite fast. Yeah, but I think this is just, the economics of it, because a biopsy will be done quickly and we can get the diagnosis quickly. I think the challenge is there in the public sector, like any other public sector. I think in Namibia, we are still in the infancy, because, we need to, educate the clinicians, especially in the peripheries, because the problem is that I think Namibia is the second most sparsely populated country, I think after Canada. So you've got a population of like 2.2, 2.3 million and the towns are very far. So one finds that it's very difficult, one, to educate, to find the doctors. 1, 2, also, there is still this notion of a fine needle aspiration. So one can tend to see that patients are coming in with very big, very huge masses. And we are trying to reverse that. But we are still trying to get our wits, and also access to the tools that are needed. I think it's also a bit of a challenge. They also have issues. So I think probably that's one thing that we'll need to get assisted with, especially with the core needle biopsies. But we'll try and talk about that. The distance I've talked about, also the human resource, like any other place in Africa, it's also a challenge that, we've got other diseases that are of also importance. So to allocate the human resource can also be a bit of a challenge. So all I can say, what is happening in South Africa, I think it's almost similar, like what is happening here in Namibia. So that's what I can say. That's my experience. But I think to me, this was a worthwhile experience. And I think you could see that it really saved lives. And I think, identifying a lymph node early, to be honest with you, it saves lives. And I think there's no doubt about it. The data is out there. If you look at the Hodgkin's lymphoma, stage 1 and stage 2, outcomes are excellent. Once you start getting to advanced disease, it's another story. So I think I would really promote this, that other centers start having their own clinic. So I think probably that's all I can say today. You're muted. We can't hear you.
Sorry, I'm muted. Thanks, Simba. That was great. And you really gave such a good picture and a real picture of what it's like. And as you've said, I don't know if Khadin wants to share the website quickly, but we can also go on. Yeah, so I think the point here is, wherever we're going to do this and work, we're now going to the Eastern Cape with Francois, with this guy. We're going to the Eastern Cape for outreach in Port Elizabeth. And it's imperative for me to work with an expert like him. And I mean, it's for a surgeon, a biopsy is not an expert thing. They think it's small fry. But the fact is, it's important that to prevent any problems, a surgeon is at hand, and a surgeon is part of this, as well as the ENT specialist. And I think that's the great thing, is that we haven't had one complication in this clinic, and it's because there's such an excellent are you playing? You can start, or must I start?
No, I will start. It's just there's some music, so I just want you to finish talking.
Okay, is there some music? Oh, I'll speak a bit louder, but it's fine. I don't have anything so important to say.
Welcome to this set of videos that we're producing on optimal outcome for soft tissue lump biopsies. And we're going to take you through various techniques of doing biopsies to ensure the optimal outcome for your patient. I'm Dr. Francois Malherbe, and I work in the breast clinic. I'm a breast surgeon at Groote Schuur Hospital in Cape Town, South Africa, and I'm heavily involved in the diagnostic services in our clinic. And we do a lot of biopsies every week, and hopefully I can teach you some techniques, show you the different needles so that you can obtain an optimal outcome for your patients. So I'm going to start off by showing you the different types of needles that are available to do core biopsies. Core biopsies are mainly used for histology. It's the main biopsy that we use, and it's the gold standard around the world to obtain tissue biopsies for most soft tissue tumors as well as breast tumors. So let me start by showing you the needles that are available. First of all, we've got the completely manual needle. These needles are quite old. They're also referred to as a true cut needle, and they are still the only available needles in some of our hospitals, and that's why I want to show you some tips and tricks to obtain the optimal biopsy with these needles. Then we've got the semi-automatic needles. With these needles, makes it a little bit easier to obtain a biopsy. And I'll show you some techniques how to get your biopsies with those. And then last of all, I'm going to show you the fully automatic needles, which actually does most of the work for you and really obtains the best biopsies. The only problem with these needles are that they're very expensive. So these needles are less expensive, and they are often the most commonly available ones. This is the handheld needles, and the automatic needles, obviously the most expensive ones, but might be of a great.
Okay, great. So I think it's over to us again. And there's a nice question in the chat box for you, Simba. You can answer that one. But just what Francois has shown here, interestingly, after he made this video, the price of that middle needle has actually come down quite a lot. And we also use that in our clinic. So it's got this own mechanism, and it's disposable. But the gold standard remains the one with the, with a gun, with that true ability to shoot very quickly and accurately. So the prices of needles have come down, and they are available at a provincial level. So it's not as if you can't use them. So what at that stage was like a long shot has now become mainstream and easy to use. And I say again, it's working with all the disciplines, with surgeons, with the ENT specialist, perhaps the radiologist, Jacques, for all those other awful bumps and lumps, that we can actually get good diagnosis. So there's a question, Simba, about the hemostatic assessment. Is that something you want to just weigh in on?
Okay, no, it's fine. I mean, to tell you the truth, I mean, it's like I mean, it's like doing a bone marrow, to be honest with you. I mean, people can do a bone marrow with patients with a platelet of 1. You know, I think the problem might be the INR. But tell you the truth, we never really did like a proper hemostatic assessment. Usually, most of these patients would have come in with an FBC, and you can check, the platelet count. But really, to just say, you know, check the INR and all that, we never did that. I mean, because if you look at it, it's a very, very superficial. Yeah, I mean, it's a very, very. I mean, to be honest with you, I think to me, the diagnosis is more important than the hemostatic assessment. I'm not saying that someone with an INR of 10 and a platelet of 0, then you do the biopsy. But what I'm saying is, you know, I think a hemostatic assessment in an otherwise normal, good-looking male or female, I don't think that, you know, one needs to go down that route and, you know, delay. Because to me, the issue is, remember, the people that we save, most of them, these are poor people. Like, I mean, like Cape Town, people travel from Mitchell's Plain is like it takes them time to get there. And then you do bloods, you tell them to come back tomorrow. They won't come back because they've got other important issues that they need to attend to. So I feel like, you know, unless if you are worried you are seeing ecchymosis or, you know, or the platelet is like 2, you have seen it. But I think for a normal person, I would just do it, you know, and compress for dear life. Thanks.
Thanks, Simba. Okay, so I'm going to conclude with just a few things about the importance of lymphoma. And I always have to tell this story. I can't stop because I think because it's not like stomach cancer or liver cancer, that's one diagnosis. We've got so many diagnoses. We must always remember that non-Hodgkin leukemia, which often includes non-Hodgkin, as well as Hodgkin lymphoma and multiple myeloma, all these things, plus a few others, make up the cancers we treat. So they are significant. They're definitely lying in the top 5, 6, if we count them all together. And in Africa, they may even be higher. Just a quick word on the incidence. This is now a recent incidence, and I must say it's higher than it used to be a few years back when it was barely 5, I think. But this is obviously not right. 7.1 is not the incidence what we should have. In Europe and in America, the incidence would be nearer 30 per 100,000 per year. And there's no reason to think that with our higher HIV lymphoma, but perhaps higher mortality, there's no reason to think that we should have so much less. So this is vastly underdiagnosed and vastly underreported. So that's clear. And I'm going to sprint through this because I still want Catherine to chat a little bit about and weigh in a little bit about the work that follows on from this. But the point that we're making is that hematological malignancies are much more common than we think. And if we look at the main causes of death in our country, then hematological diseases will not be near it, obviously, because they're very curable. So want this empiric TB treatment and the FNAs that gets done again and again. This is the bit to set the new standard, do point of care focused investigations and get accurate diagnoses. So we are now branching out as part of the cancer initiative we're doing to look at the health economics aspect of it. So the important, why do we care? Because we've actually proven now that it works, and we've proven that it actually should be implemented. But now we must make sure what we're doing, and if it's good, makes good sense to do it. And remember, if we can get good diagnosis, our patients are, as Simba said so nicely, they are at an earlier stage, they're easier curable. So we end up with more resources for the patient, for treatment, for time, care, drug access, treatment pathways, uniform guidelines. So it's important to see how we can do diagnostics the best way. And we are now also going to look at the softer things, like how does a patient experience it? What's the cost to the patient through questionnaires? And hopefully this will lead to us thinking more deeply about how we can care for our patients better and make a better case for our patients to the funders, whether they be public or private. So I'm going to quickly skim over this. This is the last part that I will chat about. And that's just, as you can see, this is how our colleagues over at the School of Public Health work out the costing and this is the excision biopsy or a core needle biopsy with an ultrasound. So, so what I can say, which is just the differences between the two, is actually not as big as I thought, because there's still personnel and still a building equipment that's used, but the core needle biopsy is a bit cheaper and the access is easier. And that's actually the point that Warisa made, is that even though it's not that much, it is about 30–40% cheap, 30% cheaper. The fact is that it's much easier accessible. We've got a 5-day waiting to get to our clinic for the diagnostic lymph node biopsy. 5 days, and I think that's very, very fast due to the electronic referral system. So if we look here, what typically happens, as we've seen with that other patient, there's typically 2 FNAs, and can you see the cost of an FNA in cytology? And it seldom yields anything, regardless of diagnosis. It's truly a test that we must think about, again, if it's not done by a very, very expert team, expert cytologists knowing exactly what they do. But a cytology done there in a clinic without understanding the predictive value of any, what are we looking for, it's useless and it costs a lot of money. So that's the old pathway. And the pathway where you still start with an FNA, but then you go to go to the excision biopsy quicker, is a bit cheaper. And if I just wanted us to think again about this young man, what all of these tests and the operation that he didn't need, what all of these things actually cost, and it almost cost him his life. And many of these patients, it does actually cost them their lives. You saw the X-ray. So this is very preliminary. Warisa has passed her master's with flying colors, but we're still kind of having a conversation about what things cost and what the actual cost of the staining for lymphoma is. But it will be exactly the same between the core needle biopsy and the excision biopsy. So I don't think we have to worry about that. The costs of actually diagnosing lymphoma or anything else in the histology will remain the same. But if we take out the gene expert on the FNA, because we don't think it's TB, then we can actually get a full diagnosis, whether it's TB or lymphoma or cancer, for a smaller amount. So makes sense. And the opportunity cost is the thing that we sometimes forget. We think perhaps that the patient can wait, but perhaps the patient cannot wait that long. And that is why we call our clinic a rapid access clinic, because the patient can really get there and can immediately be seen. And as Simba also charted, patients do not have means to keep coming back to doctors. So I'm going to now say thank you to those who worked with us quickly, and then I'm going to end with a little bit of chatting about why we do lymphoma registries and repositories. So these are all the wonderful people of our teams and all the wonderful support that we got from other sources, from our own university hospital and beyond. And then the lymphoma team and beyond in South Africa. This is the team that Simba is speaking of that actually checked all the results behind the scenes and did the analysis to actually audit what we were doing, because that is what good clinical practice would want to be. These are some of our collaborators in the picture. We've got our interdisciplinary lymphoma meeting, and we have got many people working on the lymphoma registry. The main person is Lillian, who is in the meeting, who has built an absolutely amazing database in lymphoma. And that truly changes the game for us, because now we are capable to actually take part. I don't know if Mahlatse Mankele is here today, but because we have a lymphoma database, we could work with other universities on a rare lymphoma, because we could find that rare lymphoma. So the power of disease-specific registries and repositories. So that has, for example, led us, when Catherine went to Harvard, to start doing collaborations with them, because we have, part of the work is already done, and we can now find the specimens and we can start working on them. So this type of work is the type of stuff that we can do in South Africa, and that makes us unique. The HIV lymphoma we have, the different types of lymphoma we have, and it is great to be working in a global partnership and work out these patients. And now I'm handing over to Catherine. Catherine, it will be lovely to hear what you think. And I think we can take away the video and just chat to you.
Hi, thanks, Estelle, and thanks everybody. Lovely to know that you're on the call from the names. So I'm just going to share briefly about how we've been collecting specimens from patients and linking that to a repository, and talking really about future plans, because I think although we started with an effort to bank specimens, I think we did the best that we could with what knowledge we had in terms of protocols for banking and how to store them. But I think in learning better practices, we've certainly trying to develop and grow that effort, and would love to share the trajectory that we're on. And just to say up front, if there's anything that we can share with any of you, if you're thinking about projects and what type of specimens you'd like to store and you'd like us to share SOPs, we're very happy to do that. So Estelle and Jenna have worked, and Karen and the whole team really have worked extremely hard to get a REDCap database up and running that's being used in the clinic, that stores patient clinic and pathological data. And really, it's been such a valuable resource for many research projects. And I think we're trying to carry that same model forward when thinking about the repository, and in the first place, linking the specimen to this very rich resource from the clinical data, and then thinking about how do we protect this resource, but in a way that's generous protection. We want the data to be used, and we want the specimens to be used, but we want them to be used wisely, noting that the patients, it really all belongs to the patients, and we would want research that has better outcomes for patients as the primary focus. So I think the REDCap database is really, I think, in a way, you put an upfront investment into kind of future-proof the work. And I so valued Estelle's input when we were thinking about the clinic, because my personality, I like to get things up and running quickly. Like, let's just do it. Let's just start next week. something to be said for also just starting small and doing what you can and improving along the way. My first point is just about that governance is critical, that it's a valuable resource, and of course issues of governance come in with patient consent, anonymization of data, who can access the specimens and for what purpose. And I think Stellenbosch University have done a really great job with their biobank under Prof. Schneider, and at some points it would be lovely to actually have him talk maybe at this forum in depth on those issues of governance. And then a second practical point is who's paying. I think now setting up a lab, I'm realizing it's very expensive to bank specimens. Of course, labor, somebody's doing the work, consumables, freezer space, and to think through, does that mean whoever's banking the specimens, who's paying for it, do those specimens then kind of belong to that researcher, or is there a better way to do it? And then I've already spoken about storing and linking specimens to the clinical data, which is of course critical. And then on this issue of future-proofing research, I would just encourage any of you that are doing research where you're collecting, even if it's very basic specimens from patients now, if you're just collecting an EDTA tube or, clotted tube or whatever you're collecting, to just try and think broadly if there may be questions that you would want to ask later if you get more funding. If somebody were to give you R1 million to do whatever research you wanted to do on this cohort of patients, what could you imagine doing? Because it might not cost a whole lot more money to put that in the bank. And then when it comes to writing your grant proposal, it makes it a very feasible and much more fundable proposal if you can say, I've already collected specimens and these, access to these specimens are available. Then I just want to talk briefly about the types of specimens. And I guess here is where I'm very happy if there are any questions, or very willing to share SOPs. And this was certainly something that I found quite difficult as a clinician. Of course, we don't have training in this. It's difficult for us to wrap our heads around where we can get DNA from or RNA from, or in any of these things. I just found really difficult. And now it's actually not difficult. And I think for any of us clinicians, it would actually be maybe even just a little bit of my time just talking through it now, and you'll have enough of a handle to think about it for yourself and for your research project. But if not, if you need a little bit more time, or if you want to think through, like I've said, I'm happy to help with that. So from the lymph node specimens, initially we were collecting fresh frozen specimens. So we were actually taking, and I must just actually say thank you to, we have a fantastic tech, and to Vernon and Estelle, who enabled the clinic to have such great support staff at the clinic, like Jenna and Celine, who's the tech, because without that, I think there's no ways that a clinician, unless you've got a lot of experience in doing it for a long time, would manage to get all of this right. So we've had a tech who's come to the clinic every week when the clinic is run, and so she would bring things needed for the banking, one of them being a flask of liquid nitrogen, and we were storing the lymph node tissue immediately into a cryo vial and into the liquid nitrogen for fresh frozen specimens. I have now submitted a number of those cases for sequencing, for RNA and DNA extraction and for sequencing. And we know that, the quantity of and the quality of the DNA and RNA from the specimens is good because it's fresh frozen. But there are a couple of just small practical things. For example, because we take normally 3 core biopsies from the lymph node, you don't know actually exactly where that lymph node core has gone into, because the one that's been looked at under the microscope by the pathologist may not actually be from the exact same area. And so if all the tissue is frozen, I haven't been able to then, just check that there is the 20% tumor cellularity, which is what you would want to do before sequencing. So that was the one small practical consideration. You may not even have lymph node tissue in that particular core needle biopsy. Another consideration is that you're unable to do any single cell work because the cells are not viable. And so we've modified our approach now where there's two options really for if you're wanting the cells to be viable. You can either do a single cell suspension or you can actually just store it in small pellets. So you cut the lymph node up into small pieces and then store it in much the same media as you would use for stem cells. So 10% DMSO and FPS works the best. So that's for the lymph node specimens. For the PBMCs, we have been storing PBMCs which have been really useful for germline if you know that the lymphoma is not involving the peripheral blood, of course. But they're actually a great source for germline DNA because when comparing germline to tumor, the PBMCs will have mutations that are associated with clonal hematopoiesis, which is useful so that you can kind of take those away from what you assess to be the somatic mutations affecting the oncogenesis. But again, ideally, you would want to actually have these cells stored as viable cells, and this will allow single cell work. I didn't really go into that on the lymph node, but the same principle applies. Like single cell work, it means you could then thaw them and you could run them through flow and you could select out a particular subset of cells. And you could even there's now workflows doing single cell RNA-seq. So you could look at the expression of different genes that are, differentially expressed among the different cell sets. And so for our PBMCs, now we actually have modified the workflow and we're going to be storing, so from an EDTA tube, we're going to be storing them also in the same cryopreservation media as the lymph nodes. There are some very expensive ones, commercial products on the market. They're probably marginally better, especially for the lymph node, but they're just so expensive that it's prohibitively so. Then plasma, and this is really, I think, the most exciting part. I think, the field is moving hugely towards cell-free DNA and also cell-free RNA and proteomics, and all of this is derived from the plasma. And it's quite a simple technique to just spin down and fractionate and store the plasma. Particular RNA for long-term storage, there's a special tube for that, but also cell-free DNA, there's specialized tubes that greatly increase the yield of the cell-free DNA. So we are now collecting blood in those specialized tubes before we fractionate and store. And then lastly, just to say, of course, the other type of tissue that the other sample that you may want to store is actually DNA or RNA once it's been extracted. And lastly, we are storing saliva from patients as a germline control as well. And so just to say, for our future efforts, I think this cohort of patients they represent patients where there really can be huge improvements in diagnostics. I think, of course, biopsying lymph nodes is a low-hanging fruit, and just thinking in the future about what else could be done. And with the movement towards cell-free DNA technologies, I think it's not far-fetched to imagine that we could detect lymphoma from the peripheral blood, especially thinking about patients where the lymph nodes are not easy to biopsy. And then also to subtype lymphoma. There's been the recent papers at ASH from the Lizaday Stanford group actually showed that the tumor fraction was higher in cell-free DNA from Hodgkin lymphoma, is higher in cell-free DNA than in tumor biopsy specimens. So actually they were more accurately able to genotype the tumor, the Hodgkin from the plasma. So I think it's a very exciting field. And if we start talking about it being cheaper and more accurate, doing it on the peripheral blood, we are probably going to get to a point where with the cost of sequencing declining, that it declines to parity with the cost of doing other molecular workup to really accurately diagnose the subtype of lymphoma. So those are some of our efforts. I hope that that's helpful. And yeah, we are working on this. It's definitely a work in progress and starting small, but hoping to develop something that is a very useful resource for many researchers to come, and it will actually be a useful resource to bring in more grant funding if we can show that we've got clinically well annotated specimens that have been stored well. I certainly think it moves us in the right direction. Thanks.
That was great. Thanks. Thanks, Catherine. Are there questions? And I think Catherine has stressed the fact that this is not proprietary. It's not for one center. It truly is something that everybody can work together, and there are very strong and robust rules governing the use of human tissue and the use of information. And it's never supposed to be, as you said, I've spent the money, now it's mine. That's not the point. It's quite intricate. I think our human HREC, our boards looking after the ethics, they have a lot of work to do nowadays, and that will change and change and change. But the nice thing is it's transparent, and it is something we must do. Fatima, we'd love to hear from you.
Hi, thanks for a wonderful talk. I think it inspires us. We are always battling with patients who present with advanced disease and need to be treated immediately, and it's a struggle. We think we're getting better at it, but it's always a challenge. I just wanted to share a bit of our experience at Tygerberg. So as you know, we've got a cytology team that's quite experienced, and I think our doctors are getting better at the gun biopsies and that, but our challenge is that we have limited slots for that. So to try and obviate that and to try and get a diagnosis sooner, we still use the FNAs with flow cytometry. And because the cytologists are very experienced, they are able to do cell blocks and give us a diagnosis. It's not always, but at least it gives us a quick answer as to what they think it is. And if they feel it's not good enough, then we move on to the core biopsy. So it still is not ideal, but I just wanted your thoughts on the use of flow cytometry as well. Sometimes we use that. So they look at the sample, and if it's representative, then flow is done on that. And again, we also have an issue where sometimes even the core biopsy is inadequate and we have to do an excision biopsy. And that's also a challenge in terms of finding a slot. So do you have instances where you end up with the indeterminate result on the core biopsy and need to move on to excision biopsy?
Thanks, Fatma. I'm happy to answer some of those questions. I think undoubtedly adding flow and having a specialized cytology clinic would improve the yield, undoubtedly, and especially if the flow is happening expeditiously and close to the aspirate. And I think also, and I'm not sure, correct me if I'm wrong, but I think your team are also doing IHC on the from the cell blocks. Is that right?
Yes.
Yeah, so I think those two measures hugely help. So, our aspirates, we were only doing cytology without those ancillary techniques. So I think our results are not comparable at all because the methods are so different. In terms of the repeat biopsies, 12% of our patients who had lymphoma needed a repeat biopsy. And in most of those patients, because of the same experience that you're having, we repeated a core biopsy. And in almost all of them, we got a diagnosis on the second core biopsy.
Yes.
I can't remember what proportion, but it was only, I think it was only about 3% of patients who went on to have an excision biopsy. Some of them even had 3 core needle biopsies, I guess. And I guess that's just reflection on how it's convenient. The gun is sitting in the doctor's hand and the patient sitting in front of the patient. And then the other thing that we found has helped is taking a number of cores at the same time. I said 3, but I know that we sometimes take even more than 3. And you can get an idea once you've popped it in the in the saline or whatever's going to the lab. And if you look and you see it's floating, then you know it's probably fat, or see that it kind of sinks nicely, and just have a look at it macroscopically. And that gives, I think that improves the yield from the core as well.
Yeah, it's easier when you have stable patients, because then we can schedule them, but it's the sick patient who comes and we need a diagnosis urgently. And those are the ones we sort of go first for FNAs. And
Fatima, I would really encourage you. You've got wonderful, just like us, you've got a wonderful breast surgeon, and just to ask them. I think that has helped a lot. And as Simba has also alluded, patients don't mind coming back for a second biopsy, but it's the speed at which we do it. Our clinic is built on speed. That's why we call it rapid. Rapid is the word that Catherine coined, and it really is the point. We see them within 5 days.
Yeah, so we have a weekly list with Dr. Edge. It's a weekly list, and like some of our doctors are adept at it as they got experience. So if we have a patient that they are comfortable with, we go ahead and do it without waiting for that. So a lot of the times they are able to do it. Unfortunately, we're losing our most experienced person. He's now going to hematopathology to specialize. So
congratulations. I see he's in the audience.
Yes.
We won't miss him totally. It'll get, I'm sure you'll get somebody wonderful, Fatima.
Yes.
Yeah.
Thank you. Yes. Yeah.
I think thanks for that. Yeah.
Yeah. And I would like to propose that we have a workshop that, like you have, for our medical registrars. We can schedule it and
right. Let's do it.
So would you be? Yeah, I would love that, because I think it will make life a lot easier.
Okay, so as Catherine said, we invite you to write to us, to speak to us. We would really like, we think it is important enough. We do think patients with lymphoma is very curable if diagnosed in time, or diagnosed at all. Because as I say, they are not diagnosed sometimes. They don't get to us.
Yes.
So every unit has their own strength and their own weaknesses and things that, as I said, our weakness is not good FNA. So we have to overcome it by doing good core biopsies. And I know also in Johannesburg, there used to be an excellent FNA cytology unit. So you must really know you must know everybody, know who you can work with, but we would love to take hands across the country and love to do more training. So please let us know.
Yeah. Thanks.
So the training side is mine. The clever, wonky stuff about how to freeze cells, that side is Catherine.
We can do both.
And you can also write to us at Blood SA. We will send it to Catherine if you don't have her email, or if you want to ask questions. Very happy to answer and very happy to build together. Okay, thank you. It's on the dot 30. So have a lovely afternoon.
All right. Bye-bye.
Thanks, Fatima. Thanks, Catherine. And thanks to Simba in Namibia. Bye.
Thank you, everybody. Bye.
Thank you.